Good morning, all. It's Bao. Um, it was my last day yesterday, but I'm here today for the last presentation with you all. I'm gonna talk about hyperkalemia, um, high potassium in the body. So, patient would be have a risk factor of hyperkalemia if they have chronic kidney disease, heart failure, type 2 diabetes, hypertension, progressive kidney declining, or they can also have drug-induced um, hyperkalemia, such as patient on NSAID, antibiotics, digoxin, and as well as potassium sparing diuretics. It also be food induced as well. So not only medication but also food can interact. Some signs and symptoms: patient may have muscle weakness, fatigue, muscle pains and cramps, numbness, difficulty breathing, irregular heartbeat, chest pain, nausea, and diarrhea. The complication of hyperkalemia is cardiac arrhythmia, which can put the patient at risk of cardiac arrest. Diagnosis: we would need to measure for urine and serum potassium. If it's greater than 5.5, it would consider hyperkalemia. Um, the normal range of potassium in the body is 3.5 to 5.5, so it varies between hospital to hospital on how they want to rank their hyperkalemic patients. But it would be clinically significant if the potassium greater than 6. We would also need to measure for the um, creatinine because it would show how the patient kidney progressing. And on the electrocardiogram, it would show abnormal graphs such as peak T wave, prolonged PR segment. Treatment: we can also give patient 10% calcium gluconate IV, 10 to 20 ml over 2 to 3 minutes. Um, the in the episode of hyperkalemic, the calcium in the body would antagonize the effect of hyperkalemia at the cellular level. This would affect the threshold potential and speed of um, the impulse propagation. The IV bolus of calcium gluconate would lead to toxicity due to the increase of intracellular calcium, which theoretically associated with digitalis toxicity, nauseas, vomitings, and arrhythmia. We can also promote the uptake of potassium by cells by accelerate the movement of potassium into muscle cells. These agents below are widely used to treat severe hyperkalemia at most of the hospital and um, hospital setting. Um, Regular insulin, usually giving at 10 unit IV bolus with the 50 ml of D50 water, or as infusion over 1 hour of 20 unit without the loading dose. This would lower 1 millimole per liter per hour of serum potassium. We can also give patient beta-2 agonists such as albuterol, 10 to 20 milligram by nebulizer over 10 minutes. This would give a lowering of 0.3 to 0.6 millimole per liter within 30 minutes. Sodium bicarb can be given at 144 to 400 millimole infusion over 2 to 4 hours in D5W. This would lower 2 to 3 millimole per liter in patients with severe acidosis. A combination of the cocktails, usually given with IV solution of 400 ml of D25, 50 units of insulin, 40 millimole of sodium bicarb, and bolus calcium as needed. We can also eliminate the potassium in the body by stop all the medication and drug and food that can induce the hyperkalemia. We can also use dialysis to remove it from the extracellular. We can work on the urine excretion by giving patient the loop diuretic, fludrocortisone, and sodium bicarb. Lasix usually given at a high dose, a double, at least double the dose of the oral dose if patient on Lasix at home. Um, 20 to 40 milligram of IV usually given, but patient can also be able to receive 80 milligram in severe cases. Fludrocortisone can be given up to 0.4 milligram daily for patients with kidney disease and have aldosterone resistance or deficiency. Casalax, sodium polystyrene sulfonate, usually given for either acute or chronic um, hyperkalemia. It can be given either oral in 50 gram of with 30 ml of sorbitol solution, or given rectal 50 gram in a retention anemia. Adverse effect of Casalax usually bowel obstruction. Um, Patiromer, usually given for chronic cases, 15 to 30 grams per day, would increase the daily fecal potassium by approximately 15 to 20 millimole. And also ZS9, usually given for acute cases, but is not commonly used at most of the hospital setting. Now we go into the patient case of one of our patient here. ES is a 64 years old female who had a history of past post-transplant of 1 year and 7 months. She also has past medical history of CKD, diabetic, MI, toxic encephalopathy, and GERD. Her past surgery including 2 times of renal transplant, a stent placement, coronary artery bypass, and RUE graft. Social history: she's an extensive smoker who reported quitting smoking 3 years ago and lives with her family. Her family history: positive CAD in her dad's side. So she was admitted to the to Crozer on October 2019 with a chief complaint of chest pain, dyspnea, myalgia, dry cough, discomfort on her left side, which did not radiate. The vital sign at the ER was 100.6 Fahrenheit. Respiratory is 16, pulse is 16, blood pressure 158 over 73, and oxygen's 97% room air. Her lab level is measured, and we're looking at the potassium here, which is 5.2. Not too high, but would be significant in her case with her given kidney function. The BUN is 45 and serum creatinine is 1.4, which was mildly elevated. D dimer is 1.26. BNP is equal to 893. Troponin also measure echo on March of last year show the EF of 60 to 65%. So she has mild elevated potassium and sign and symptom of chest pain, dyspnea, and muscle ache. In the ER, they gave her IV fluid, 500 ml of normal saline. This is listed her home meds. The diagnosis at the ER is CKD, acute exacerbation of diastolic heart failure secondary to CKD. Discharge planning, they resumed her home med and started fish oil 1 gram oral by, daily. Imdur 50 milligram ER oral daily. Lasix 40 milligram daily. and sodium bicarb 650 milligram oral daily. So the two in red, we can see it. They're giving her fluid, the water pill to reduce the fluid in the body due to her CHF, but also it also can be used for her hyperkalemia as well. She's not too elevated in the potassium, but it would be um, a little bit severe in her with her kidney disease. And that was it. That was my presentation. Thank you for your time, and again, I really appreciate the time that I was being there, and I really enjoy hanging around with everyone at the clinic. Um, I will hop in. I have family around closer, so I will hop in just to say hi when all of this pandemic settled down. Again, thank you so much, everyone. I really enjoy my rotations at the transplant unit. Thank you.